Paddy talked about being out of your comfort zone. I think I'm a prime example right now of being out of my comfort zone, but let's go. We've entitled ours, as you've heard, Audit in Motion, and I'm from the Network Development Team 1, and my colleagues to my left here, we've got Edith McMacken, Fiona Gilmore, who can't be with us today, Geraldine Tracy, Jean Barber, Nuala Ginley and Trish Curran, who were all part of this initiative that we undertook. And I suppose that Paddy has already alluded to the problem of constipation and how difficult it can be, and certainly in the literature it highlights the problem, the incidence of constipation, how it is a significant problem and how it can cause great discomfort and even sometimes distress for those people that are experiencing it. And yet the literature would also say that it's often under-identified, it's under-assessed and it's often poorly managed. So we are certainly looking forward to the launch of the guidelines that are due to be hopefully launched any day now. And there will be an accompanying audit tool along with that. And so we have been given the opportunity within our group to actually test and pilot the audit tool which will accompany the guidelines. And so the aim of our initiative was to pilot or test the constipation tool in a variety of adult palliative care settings across the whole of the island of Ireland, so north and south, to see if it was suitable and applicable within various clinical settings. And our objectives were, first of all, to get a snapshot overview or a very basic overview of current practice within a range and variety of clinical settings in palliative care, all adult-based because that's what the guidelines are focused on. We also wanted to determine the applicability of the tool within each of those individual settings, but as well as that we wanted to look at the experience of those using the tool and how usable they found it and perhaps any suggestions that they had in relation to the tool, and as a consequence to make recommendations in relation to the design and content of the tool for future use. Okay, and the process then that we undertook as part of our network development team was we obviously had to develop a proposal because this was something we had to take back to each of our organisations and to the audit groups within each of the organisations that were going to participate. So we pulled together a proposal that we could present so that was standardised within each organisation. But we felt, as we said, we wanted to explore the clinician's experience of using the tool. So we developed a very brief questionnaire, which was for staff, and that was to try and elicit feedback on the design and how usable the tool itself was from their experience. We identified pilot clinical areas from within our network, so all the areas from the members of our network team were represented in the audit, so that we got geographical representation across the whole of Ireland and also from an appropriate range of settings. We also felt that we needed to have some kind of information for staff to explain the background to the audit, the rationale for the audit, and what obviously was expected of them when they undertook the audit. And then we had to seek approval from within the audit groups in our organisation. So we each went back to our own organisations, presented our proposal, got approval, and then we identified colleagues within our own settings who were actually going to help, who were going to participate in the audit, and sat them down, give them a written and a verbal explanation of what was expected. And then we just did the snapshot over a one-day period. We collected all the data from that, and actually alongside this tool that has been developed with the guidelines, they have an Excel database, so there's a master copy of that which does a lot of you can collate your data on that, it develops aspects of a report and various other things. So that was learning in itself. We've all collected and collated data before and used Excel, but this was a unique tool, and that proved challenging to try and do that remotely, if we're being honest. We tried to follow an audit cycle, as we would all know the audit cycle from, and the recommendations had been set within the guidelines, and therefore the standards for our audit were based on those recommendations. There's already a data collection form which has been developed, so a lot of this work was done for us, and we were testing that tool. So we used the data collection form which is with the tool, and we collected the data, and then we were comparing the results to the recommendations or the standards within the guidelines. They would recommend that compliance should be 100%. Obviously it wasn't in this case, but that's what we're aiming for. And obviously if you were doing this as a full cycle and repeated audit cycle, you'd formulate an action plan and re-audit using the same tool and measuring practice. So we had, the good thing that we feel was that we had actually over 100 patients within this audit sample from the right across north and south of Ireland, and I think that's unique in itself, and I think we need to sort of highlight that. So, you know, it's a reasonable sample. Obviously within each unit the numbers were smaller, but overall 101 patients. So we had from specialist palliative care inpatient units, community palliative care, day hospices, acute hospital trusts. We had nursing home representation, we had palliative care teams in the community, we had a cancer centre involved, and we had a specialist palliative care unit within an acute hospital. So we got a good range of clinical areas represented. The areas that are included in the audit, they look at assessment, whether was a comprehensive assessment carried out, and there's lots of different aspects of that. And we'll talk about that when we come to some of our suggestions and how that was actually asked and addressed. They also looked at the practice of digital rectal examination, or DRE. That has been controversial, again, we'll look at that. They looked at if a plain film of abdomen was undertaken, was there a specific rationale for doing that, or was it just randomly done, as sometimes happens. They looked on was education given on non-pharmacological measures in the management of constipation. It explored whether non-pharmacological strategies had been used, not so you could be teaching the patient, or you could be utilising strategies and not actually teaching the patient to do that for themselves. It looked at prescribing practices, and it also looked at bowel obstruction and the use of specific pharmacological agents in bowel obstruction. Our questionnaire then looked at what was the experience of using the tool, how people actually felt about looking at their own practice, because it's very much about you as a clinician taking that tool and looking at what's being done, slightly different from some previous audit processes. Was it applicable within those specific, and I can't speak, clinical settings? Did the clinicians feel that there needed to be any adaptations made? And what did the clinicians feel from actually using the tool? And so looking at reflection. So we have obviously analysed these results in a lot of detail, and it's in our report. We can't actually circulate the report today or even go into too much detail in this presentation because the guidelines haven't been launched. And today, you know, obviously they don't want the guidelines circulated, the draft guidelines circulated, or their tools circulated yet because the official launch hasn't taken place. So obviously we can't share our findings in detail yet, but they will be available. But overall, when we looked at it, the auditors were very receptive of auditing their own practice, and they welcomed the use of a tool. So we felt that actually that positive response lended itself to considering a similar approach with other guidance documents, perhaps that were being implemented locally and nationally. They also found that an audit tool was a good resource for education if used in the way that was designed, because they had the recommendations within the audit tool, and therefore it was flagging up good practice as you were auditing. And by doing that, it was educating and training staff. But the flip side of that is that some people, obviously, some people did not agree with all the recommendations. So, you know, there are questions as well. And that the auditors welcomed the opportunity to reflect on their own practice. So some of the results highlighted that there were gaps in current practice in comparison to the best practice approved recommendations. And this was evident not just in the acute settings, but also in specialist palliative care settings. And so we weren't achieving 100% in a lot of the things, and that's okay, we know that. That's how we're going to learn from using the tool and from the guidelines. Some things were very good, others we weren't doing so well. But some of the practice recommendations were questioned. So, you know, the guidelines are new, they're looking at new evidence, so it may challenge some of the things that we actually do currently. And so some people were questioning that and looking for further clarification, and that's something that will be addressed hopefully whenever the guidelines come out. And that may require further education and training, but it might also be, I mean, I know with the guidelines that they're saying that, you know, you have to use each organisation, there's a disclaimer that you can use clinical discretion and etc. But I think if it is going to change practice or challenge practice, there will need to be some kind of education and training. One of the big things that was a consistent challenge was the recommendations related to digital rectal examination. Huge issue because, and certainly in Northern Ireland, it's not routine practice for nurses to undertake this. And there has been, previously and years ago, the training opportunities were provided. I had my name down for one. They were cancelled because of lack of interest. People are frightened, they're scared because there's no real formal guidance in relation to this, certainly in the north. And I know in Southern Ireland, from what I'm hearing, there's a similar situation. So lots of concerns were raised about roles, responsibilities and competency levels. And that's going to be a big challenge if these recommendations are endorsed. And they also recommended they asked about plain film X-rays and were they done for patients in specific situations and for specific reasons. And it was highlighted that in some clinical contexts, such as nursing homes, it might be detrimental for patients to actually take them out of their nursing home to an acute hospital, have an abdominal X-ray. That you would need to use your clinical judgment in those certain situations and weigh up the benefits versus the problems associated for the patient. Some of the questions were very ambiguous, and therefore people weren't sure how to fill in their answers, and therefore we're not sure whether we got really accurate data. So again, hopefully those that have developed the guidelines will ask us for, or allow us an opportunity to come and speak to them and perhaps clarify some of our findings. Well, we are going to ask for that, yes. We also felt there needed to be explicit instructions just as to when and with whom the tool should be used, because if you just did a snapshot with all palliative care patients, a lot of it might be not applicable. So they need to give guidance as to when. Is it only patients who are constipated, or do you do your audit with all of your patients in your caseload, etc.? Some of the questions, these are the recommendations, some of the questions need to be reviewed and made more explicit and concise. And in particular, there were questions like the comprehensive assessment. There were maybe 6 or 7 parts to that, yet you could only give one yes or no answer for the whole thing. And some people might have done 5 out of 6 of those, but because they hadn't done the 6th one, they had to say no. So they need to be more explicit. Certainly the tool may need modification to suit various clinical settings because some people felt it wasn't applicable or appropriate to their setting, but perhaps if the questions were reworded or made more explicit, it may actually fit those different contexts. There was a not applicable section, which you ticked, but there was really very little room to write why you were deeming this particular question or scenario to be non-applicable to the patient. And therefore, in interpreting and analysing the data, it made it really difficult because you really couldn't make it, some of it was meaningless. So I think they need to be more room for comments, more room for rationale for different decisions. Perhaps even knowing things like there was nowhere to put that the patient's diagnosis, etc., and perhaps other information related to the patient, which might again be more help for more meaningful interpretation of data if you knew the particular diagnosis, perhaps factors which were contributing to constipation, had they cord compression, whatever. Some people suggested that an appendix at the back of the guidelines with a flow chart outlining specific management of constipation would be really useful. We have recommended that the issue of DRE needs particular attention, and if the recommendations remain unchanged, there needs to be a robust competency-based training programme and assessment process related to that. But it is going to be a huge change in practice. And given that some of the recommendations from the document do differ from current practice, if they're going to be implemented in trusts or various settings, they're really going to have to be endorsed by those organisations for staff to be able to accept them. We also felt that this audit was undertaken it was nurses really that were the auditors, and so it remains to be seen what challenges there are when actually implementing this with other disciplines, with our medical colleagues, etc. And perhaps the group that have developed the guidelines need to consider that. And certainly just the challenge of the Excel database, sometimes just when we looked at their report, how the findings of the report and the statistics were actually documented and recorded didn't reflect the questions that had been asked. So again, that's perhaps something that could be looked at. But overall, as we said, people find this, it's a tool, it will be a good tool to use. It's an education mechanism, it's a means of reflection. Certainly from our perspective, we just highlighted some of the challenges which everybody else has. It was, just trying to do this within the constraints of your day-to-day job, and new technical issues for us in learning how to remotely trying to access and input data from multiple sites with fairly novice users, and learning the skills of teleconferencing and various other things. Ended with opportunity because we'd just like to thank for the opportunity of actually undertaking this audit, for the opportunity of actually being given the opportunity of actually providing a voice, hopefully, to those that have developed the guidelines, to make recommendations. And we also see it as an opportunity in the management of constipation that these guidelines are going to be launched soon and hopefully will help to change practice. So thank you.